Hello, everybody, and welcome. This is Steve Warshaw with HealthCurve Analytics and Heidi here in Missouri. It is just a minute or two before, maybe right on 10 o'clock for some team members. We're going to wait just a little bit longer for some other team members to go ahead and filter in. So give it just another minute for some team members to come in, and we'll be right back with you. Thanks for joining us, and be with you soon. Thank you. Alrighty, hello everybody. It's just a little bit after 10 o'clock, so we're going to go ahead and get going. Probably have some other team members join as we go through, but that's okay, kind of do the introductions. Looking at the list of attendees, I recognize a fair amount of names on the list today. I'm Steve Warshaw. I'm the Director of Outreach and Education for the Missouri Hospital Association and Heidi HealthCurve Analytics. For those of you who have yet to meet, welcome and thank you for joining me. I'm also joined by Brian Waterman, who is our Vice President of Business Development and Analytics. So Brian, thank you for joining me. And I'm also on the screen joined by SpectrumMedics, which is our partner that we have to go through and kind of the subject matter experts on MACRA and MIPS today. So to give everyone just a little bit of a background on what we're going to be covering today and the agenda, over the last several months, so kind of the beginning of 17, basically throughout the year, when I was out at hospitals and some other team members within Heidi and MHA, we'd been hearing some confusion and some comments and some questions at an increasing rate crop up on the MACRA MIPS payment structure coming out from CMS. And the more we looked into it, the more some of the Missouri hospitals, participating hospitals, had questions on it. That is not a particular core competency of Heidi in terms of going into disparate EHR systems and extracting quality measures out. We do a ton of work on core measures and the HCAHPS and some of the other CMS programs such as readmission and hospital-acquired conditions. However, this wasn't something in the area that we are really in with data. We want to be your go-to data company, but this was not something in our field. So what we do is, in cases like this, we find kind of the preferred partner on that solution that has that level of knowledge and depth and experience in handling those highly technical situations and solutions. So the mid part of last year, we partnered with SpectrumMedics, great organization located in New Jersey. And going through this, they were kind of able to answer all these questions and really provide that support structure, not only for us and the Missouri hospitals, but actually provide a solution and answer the question and really be the robust partner and source of knowledge on the MIPS MACRA payment structure. So that's just a little bit of a background on kind of where we're at today. So we're partnered with SpectrumMedics. You see all those email blasts come out for me. I'm sure you get tired of those, but I apologize. So that's kind of the background and the introduction of what we're going to cover today. Could you move to the next slide? Okay, so on the SpectrumMedics side, I have the pleasure of introducing Mark Bryant. He is the Director of Sales with SpectrumMedics, so responsible for the new business development and all the client relations. And we're also joined by Christine Wismer, who is the Senior Business Analyst for SpectrumMedics, and she is kind of a wealth of knowledge on the MIPS payment solution. So it's a lot of the technical side on those numbers of inclusion, exclusion criteria, and all that fun stuff that is CMS pushes out through the technical side. So those are the team members that we have in from the SpectrumMedics side. So go ahead, next slide. So quick agenda. We'll just do some of the background on the MIPS and the Bipartisan Budget Act of 2018. Then we'll spend a fair amount of time on numbers 2 and 3, which is the hospital-based program reporting and the MIPS financial exposure. I know most people are interested in that. There are some large amounts of money that are at risk to either be drawn away from you, or this is very similar to value-based purchasing for hospitals. There is a sum of money that actually become, a payment adjustment on the positive side to the black. So I know a lot of team members, as we move out, say, hey, I know about MACRA, I know about MIPS, but I don't know the details around this. What is actually at risk, or what can I actually get back by participating in doing this? Then we'll actually go into the SpectrumMedics eMeasures 360 for MACRA. So that's just kind of a brief agenda. At this time, I'm going to go ahead and pause. If you have any questions on anything we just brought up, that's great. I tend to do this on a daily basis, so I blow through some stop signs. So if you have any questions, go ahead and submit those. You should have your GoToMeeting application on your desktop. But with that, I will go ahead and turn it over to Mark Bryant. Mark?
Thank you, Steve, and thank you everyone for taking the time today to attend our webinar. We look forward to educating you a bit more on MACRA and specifically to MIPS and addressing any questions at the end. And we're grateful for the relationship with HealthCurve Analytics to allow us this opportunity to speak with you today. For my opening slide, just to give you a little background on us, and then I'll turn it over to Christine for the meat of this presentation on the education side. But SpectrumMedics, we've been in business for a little over 9 years, founded by Dr. Raj Lakhanpal. He's an emergency room physician and surgeon by training. And we have a mission of helping our clients transition to value-based care. And we do it in 3 ways. First is helping our clients wrap their arms around the various data that they need to utilize for quality reporting, and I'll speak to that in my section at the end, along with measures reporting, so both for the ambulatory and the inpatient, and we'll focus today on MIPS on the ambulatory side. And then population health analytics, and that's really to support any transition under MACRA to advanced alternative payment models such as accountable care organizations. We can support in analytics there as well. We're not going to focus on that today, but we certainly have that competencies if you need support in those areas. So with that, I'm going to turn it over to Christine to start to speak through MIPS.
Thank you, Mark. Thank you for joining us today. So first I'm going to touch on the Bipartisan Budget Act and how it affects MIPS specifically. So just to familiarize the audience, President Trump and the Congress enacted about a month and a half ago, back in February, the Bipartisan Budget Act of 2018. And basically it had some direct impact on the MIPS program. And you'll see on the slide there are 3 key ways that it impacted. The first way is that, as you probably are familiar, the MIPS program has a number of performance categories. One of the performance categories is the cost category. And CMS was going to basically have this performance category weighted at 30% of the participants or the eligible clinicians' MIPS scores starting in program year 2019. One thing that the Bipartisan Budget Act is doing, it's kind of easing the requirements here for clinicians and groups, and essentially saying that instead of having that ramp up of 30% for 2019, CMS is going to ease off on the requirements and basically say we'll have a little more gradual transition in moving from the weight of this particular performance category, which this year in program year 2018 is weighted at 10%, that they're going to have a more gradual increase, getting up to 30% of the MIPS score by the year 2022. So that's one thing that that this particular act is enabling or is allowing, and it's really, I think, to give clinicians and organizations a chance to really understand this particular category and to put a strategy in place and how they're going to deal with it and be successful with this particular performance category. Another area that this particular act has affected is related to the Medicare Part B charges that are basically covered both under the low volume threshold that MIPS has, as well as what charges the payment adjustments that MIPS imposes will impact. So basically starting for this year, the Medicare Part B charges are going to be limited to the covered professional services. So really the big impact here is that the Part B drug costs will not be included either in determination of the low volume threshold that determines whether a clinician or group has to MIPS or is exempt from MIPS, as well as the fact that whether it be a positive or negative payment adjustment, that would only be assessed on the Medicare Part B covered professional services, not on the Medicare Part B. I think one of the reasons or the rationale behind this is that certain specialties are more affected by the Medicare Part B drugs than others, and so in some ways it may level the playing fields, like oncology, for example, does have a lot of Medicare Part B drugs, so the implication of this would have a great impact on them. So I think in some ways CMS is trying to level the playing fields a little bit across specialties. The third point worth noting is that CMS has decided that they're going to have a gradual transmission or transition to the performance threshold that's the mean or the median. So just to step back a minute, your MIPS score, the way that it works is you have to basically get to the performance threshold that is set per performance year. If you essentially achieve that performance threshold, then there'll be no impact to your MIPS or to your Medicare reimbursement. CMS for, say, this particular program year 2018, that's set at 15. What CMS was going to put in place starting next year in program year 2018 was they were going to make that performance threshold be equal to the mean or the median of all clinicians. So that would essentially say that half of the clinicians, organizations, essentially would be negatively penalized by the MIPS program. Again, CMS is kind of backing off from that a bit and some of the requirements, I think, again, to help clinicians and groups really get a better understanding of the program, get a quality improvement strategy in place that they need to so that they can be successful under MIPS. So they're just some highlights of really how this particular act has a major impact on the MIPS program. But some of the other takeaways that I would say is that it just reinforced the fact that MIPS is here to stay. They aren't doing away with the QPP program, and in some ways, with some of the easing of some of the requirements, maybe some of the clinicians and organizations will decide to stay in MIPS a little bit longer and not make that transition to the advanced alternative payment model that they may have without some of these easements. Next slide, please. All right, so this particular slide is probably familiar to a lot of you. As I mentioned before, that MIPS is comprised of 4 different performance categories: quality improvement activities, advancing care information, and cost. Basically, these 4 categories contribute to your MIPS score. They haven't changed since 2017. In 2018, there is actually the cost category is weighted at 10%, and the quality category drops down to 50%. You might take a look at the duration of the reporting periods for the different categories. Improvement activities and advancing care remains the same as it was in 2017. In 2018, it's a full year for both cost as well as for the quality. As I just mentioned, with the Bipartisan Budget Act impact, instead of having the cost category jump to 30% of your MIPS score, CMS is going to basically have a more gradual increase. So it'll be either anywhere between 10 and 30, with having to hit 30% by calendar year 2020. Next slide, please. Okay, I think we're going to do a survey here. What do you expect to be your biggest MIPS reporting challenge in program year 2018? So if you could take a few minutes and respond to that question, that would be great. Okay, I think we're going to be closing the poll. So looks like the results from the poll, it looks like Steve was right on. Forecasting MIPS score and payment adjustments seems to be of the highest concern to many of the audience here. Some other ones that are noteworthy are identifying resources for MIPS, as well as collecting the data necessary, I guess, to do the measurements. Yeah, so, all right, so we'll just move right on. Thank you for your participation in that. Given that this particular webinar is focused at the MHA members, we're going to talk a little bit about the hospital reporting program in terms of some issues or concerns related or relevant to that audience. Okay, so first off, before we begin, just makes sense to review who has to participate in MIPS. This was something that we got some feedback on in some of those discussions that Steve was talking about with some of the MHA members. So basically with MIPS, if you bill Medicare Part B, and if you're one of a certain set of eligible clinician types, then you have to do MIPS unless one of these exclusion or categories. So I'm just going to go over this a little bit. So in calendar year 2018, or performance year 2018, that's the year that we're in now, the set of clinician types is exactly the same as it was in program year 2017. If you look at the left-hand side of the table that's shown on the screen, you'll see it's the physicians, the PAs, NPs, CNSs, CRNAs. So those are the clinician types that are eligible for MIPS. Going forward in program year 2019, CMS will be adding to that set the additional clinician types that you see on the right: TOT, language pathologists, nurse midwives, psychologists, social workers, RDs. So they also will have to participate. So essentially, if you're on the list, you bill Medicare Part B, you have to participate in MIPS unless you meet one of the exclusions that are noted below. And that's really if you're participating, you're a QP, what they call a qualified participant, in the an advanced alternative payment model, or a partial QP in the advanced alternative payment model, then you are exempt from MIPS, as well as if you're newly enrolled in Medicare, you're also exempt from MIPS. And then something that I mentioned previously, or I alluded to, was the low volume threshold. So essentially, if you don't bill a lot of Medicare Part B, essentially under 90K of Medicare Part B billing, or see fewer than 200 Medicare beneficiaries, then you also don't have to participate at MIPS or participate in the MIPS program. You're exempt. And that basically, what I would suggest that you do, if you haven't done so already, is CMS has this lookup tool where it really will show you your eligibility and whether you meet basically are eligible for MIPS. If you don't want to, if you don't have to participate in MIPS, and do it on a voluntary basis, although you wouldn't get any positive payment adjustment out of it. One thing that some of the members that we talked to were asking about was rural health clinics or FQHCs, and if you bill exclusively under those payment methodologies, then you don't have to report it in MIPS. But if you do bill the physician fee schedule, then again, what's on this chart in terms of eligibility would apply to you. And also in our discussions, critical access hospitals also asked about their eligibility, and I guess it depends on your method of billing. So I guess they talk about method one, critical access hospitals, only the clinicians that bill the Medicare Part B allowed charges, they essentially have to participate in MIPS. But for the method two that reassign their billing rights to the critical access hospital, then they would have to participate in MIPS. Next slide, please. One decision that you have for MIPS is basically how you're going to report. CMS provides a few different options here. You can report as an individual or group or a virtual group. A virtual group is a new concept that CMS came up with to basically leverage some economies of scale of small provider organizations with teams less than 10 clinicians or solo practitioners to band together and form a group. Although the deadline already passed for 2018 in order to make that happen for the 2018 program year. The majority of our clients basically use the group reporting option. With the group reporting option, CMS defines a group as a TIN. So if you had an organization that had multiple TINs, each TIN would comprise a group. If you do decide to use the group reporting option, then all the performance categories that were described, quality, ACI, IA, all have to be, that group reporting option has to be used for all of them. Basically, you aggregate the data across the TIN, so it does offer some simplified reporting, has some other advantages, like for quality measures, there's some case minimums that CMS has, so for the, when you're doing it at the group level, you can basically exceed those case minimums because you're aggregating across the group. There's some also advantages related to the advancing care information, where maybe as an individual, a clinician might not meet some of the base measures, but as a group, they're going to be able to take advantage of the aggregation of all clinicians base, as well as some things related to. Bottom line from this, though, is that if you report as a group, everybody in the group gets the same MIPS score, and everybody gets the same payment adjustment. Next slide, please. Again, given the audience that we're talking with, just figured it would make sense to touch on hospital-based clinicians and the impact here. So just going to say what is the definition of a hospital-based clinician. So from CMS's perspective is if 75% or more of your services are performed in any of the three places of service, the ER, hospital, campus outpatient, or inpatient, then you're defined as a hospital-based clinician. If you are a hospital-based clinician, you still have to do quality, you still have to do improvement activity, but you can get out of ACI. Essentially, CMS would then re-weight that particular category to the quality category. Just one thing to note, though, if you are using group reporting and you essentially like to not have to do ACI, CMS will only recognize, give you this basic automatic reweighting for your TIN or for your group if 100% of the clinicians in that group basically meet this definition of hospital-based. So every clinician in the group has to have 75% or more of their clinicians' services in these three places of service. And again, as mentioned, then the reweighting of the 25% would go towards the quality. Other things to probably note is be aware there's another category called non-patient facing. A lot of radiologists fall into that category. Some of our members, the clients that we work with in the hospital environment, fall into that category. Again, they also could be exempt from ACI. It's a little bit different because only 75% of the members or the people in the clinicians essentially have to qualify. And it's also ambulatory surgical center that behaves analogously to hospitals, hospitalists. Okay, next slide, please. All right, as I mentioned, that although you may, if you're hospital-based, be exempt from ACI, you still have to do quality and you still have to do improvement activity. This particular slide just highlights some of the quality measures that may be applicable to hospital-based clinicians. This is a subset of the list that's on the website. Definitely you can take a look here. Take a look on the website. This particular chart not only shows the measure, but it also shows the different reporting mechanisms that can be used to get the data to CMS. R for registry, HR direct, or claims for C. I think as probably Mark will be talking about, we're both a qualified registry as well as a QCDR. And so we provide that service to our clients and support all of the measures that the registry CMS has identified as registry measures. Another thing to note is, as I mentioned, you need to do the improvement activity. There are a number of different activities that you consider if you're hospital-based. There are various QI program-related activities, prescription drug monitoring programs, use of decision support. There are a variety of activities that could be applicable to hospitalists. I think CMS now has upped the list to 112 from 92 last year. So I definitely want to take a look at that and take advantage of that to improve your MIPS score. Slide, please. Okay, so as Steve mentioned, one thing that seems to be cropping up as a concern for the members is what's the impact financially to MIPS. Next slide, please. So payment adjustments, I've kind of thrown that out quite a bit. As you'll see from the top portion of the slide, it shows the payment adjustments for the MIPS program. One thing to note, as you're probably aware, the way that the program is structured is MIPS has a performance or calendar year, and then they have a payment adjustment year, which is 2 years in the future. So for example, currently we're in program year, calendar year 2018 of the MIPS program. How well or how poorly you perform in this calendar year will have an impact on your payment year 2020 Medicare billing. So for every claim that basically comes through starting from January 1st of 2020 through December 31st of 2020, you'll have that payment adjustment tied to it based on how well you perform in this performance year. If you take a look at the top of the slide, you can see that CMS basically is ramping up the penalties and the incentives. 2020, it'll be 5%, then goes up to 7%, and then finally to 9%. And one thing that the Bipartisan Budget Act did confirm is that the program is in place and those payment adjustments and penalties will continue. Just a note that's on this particular slide is related to the advanced alternative payment models. And again, no change there, that lump sum payment of 5% incentive will still be in place payment years 2019 through 2024. Next slide, please. All right. So you saw what the payment adjustments are. This is really tells you how to translate your MIPS score into those payment adjustments. As I mentioned about before, the performance threshold. As you see on the slide, the performance threshold is essentially set at 15 points. So if you have a MIPS score of 15 points, you essentially get a neutral payment adjustment or no impact to your Medicare billing. A score below 15 is essentially going to give you a negative payment adjustment. Scores above 15 are going to yield a positive payment adjustment. There's a sweet spot at 70 and above because CMS not only has this budget neutral pool that they're essentially money they're taking away from the people that basically don't perform well in MIPS, and they redistribute it to the clinicians and groups that are performing well. That's the normal budget neutral payment adjustment, but that sweet spot above 70, you can tap into another reward pool that CMS is funding. It's $500 million per year through performance year 2022, and essentially you could take a share of that if you get a MIPS score above 70, and that's what we're targeting for our clients. That's our goal. Just other couple things that are mentioned on this particular slide as a way to bump up your score in 2018 that weren't there in 2017, related to some bonus points for treating complex patients, as well as if you exclusively use a 20 edition of Next slide, please. So this is sort of a famous diagram that's in the calendar year 2018 QPP legislation or rule. This slide really shows you basically how to translate your MIPS score into your payment adjustment. So as that little chart that we looked at the previous slide, if you take a look at the x-axis is essentially your MIPS score and the y-axis is essentially the payment adjustment. If you look at that point of a MIPS score of 15, you're essentially going to get a neutral or a 0 payment adjustment. And you can see as you go from 50 to 70, that's really tapping into the budget neutral, getting a share of that budget neutral reward pool, and then you can see that discontinuity at 70. So anything above 70, you're essentially tapping into both reward pools, the budget neutral reward pool as well as the exceptional bonus pool. So you can take a look on this particular chart, and you can see where you stand. I guess one thing that you may ask is, why isn't it 5%? CMS has to scale based on the number of clinicians that will basically be taking a share out of the reward pools, whether it be the budget neutral reward pool or whether it be the exceptional bonus pool. So this is scaled with some predicted scaling factor that CMS anticipates. The other thing to note is that if you have a MIPS score on the x-axis that's below that performance threshold, then CMS is essentially going to take money away from you up to 5%. Slide, please. Another point that I want to make, besides the financial impact of MIPS, the other impact that really is a lot of our clients are concerned about is the reputational impact. CMS will be publishing the MIPS scores as well as the measure data on the Physician Compare website. Oh, I'm sorry, I think we have a technical difficulty here. Back to the beginning. Okay. Sorry about that. Bear with us for a moment. There we go. Okay, we're back. Thank you so much for your patience. So just the thing to note here is that not only will there be a financial impact, but there will be a reputational impact since CMS will publish the data. They will have profile pages where they'll publish the MIPS score. For certain measures, they're going to give a star rating between 1 and 5, and then all the data that you submit to CMS is basically fair game. They'll include it in their downloadable database. The expectation is that third parties will essentially take that data, like a HealthCurve or other entities, and use it in order to make it available, whether it be to consumers, patients, employers, other organizations. So it'll really be a competitive tool. It'll be a way that you can use to compare clinicians as well as organizations to each other. So that's something that you definitely want to be aware of and have a strategy in place for MIPS program in order to be successful with that. I'm going to turn it over to Mark.
Thanks. Thank you, Christine. And so now we're going to launch our second survey question. What is your payment adjustment expectation for MIPS in program year 2018? Don't mind taking a second to answer this. All right, we're going to launch the results from this. Okay. All right, it looks like most folks, at 43%, are expecting a positive payment adjustment plus the exceptional category, so that's great. Hopefully we can all get there and avoid the neutral payment adjustment as 36% have indicated. So any education that we can help in supporting you through that process, let us know. All right. So for my section now, I'm going to give you a little bit background on how we support MIPS from a technology perspective and from a team perspective. I'm going to launch our demo first. Excuse me, we're just closing the poll real quick. So I'm going to show you a little bit about our program. So bear with me as I open up our portal. It's a web-based portal that we have. You would log into it. Just demo with synthetic demo data for this. So you would have your real information in this when you logged in. And this is going to bring you to a place where you have a couple different roles. You have an executive role, and so this could be an executive of your health system or your hospital or your provider organization that's looking at a whole on how your tax identification number, because remember you have to submit MIPS via TIN, so how your TIN is doing. And then there's also an analyst role or an informaticist role that gets into the patient level details. So we kind of separate out HI within those roles for that. So as a help from an executive role, so the first screen I'm going to show you, and this is a view if you have multiple tax identification numbers. If you are part of a large health system and you have multiple tax identification numbers, you can have one scorecard here where you can track how are your different practices, hospitals, facilities, however name and convention you wanted to call them, how they're doing, and how they're doing at this point in time against the total composite score, which is going to indicate whether you're tracking well to get into the bonus pool, and against each of the 4 categories. So you can see how each one of them are doing and affecting your overall score. Everything is color-coded, green meaning you're in that positive category, orange you're falling just short, and red if any of the categories are underperforming. So if we look at one particular hospital or TIN tax identification number, if you're just one location, this is the screen that you would see where you can look across and see each of the categories, what's the total composite score at this point in time, how is that driven via quality, advancing care, improvement activities, and cost. And then you'll be able to drill down into each of the categories to see individual performance. So first, and the most important, looking at the quality category, based on the measures that you select to track for this tax identification number, you'll be able to see what are those measures. We'll give indications which ones are outcome measures, which one lower rates desirable, indicated by a green arrow. And we built in the decile system. So you'll be able to see what the bottom decile is for a measure and what the top decile is, which ultimately affects where your score is. So at this point in time, you can see for this measure, it's maxed out. It's hit the 10 points, so you see that it's doing well. This measure is in orange. It's in the 4th decile, so it's only earned 4 out of 10 points. And this measure is underperforming. So it's earned a minimum of 3 by submitting some type of performance, but it hasn't met the deciles yet. And so for here, you can then drill down further, and we can show you trending on a measure. We can show you what measure performance, what's that look like. So for this measure, how many on the denominator, how many met performance, how many patients did not meet performance. And we can also show clinician comparisons. So if you're reporting as a group reporting, it's still important to be able to see how each of your individual clinicians are attributed to this measure. So you can see who's performing well or who's underperforming. We can also offer individual reporting, not as group, whereas when you came in, you'd be able to see each of the individuals, their own measures that they've selected as well. So we give that functionality too. Going back to this screen, we can also track advancing care. So we can show you which of your base measures. We can work with you on an internal target, show you which particular advancing care measures have extra performance scores that are tied to them that you can earn. We can track improvement activities. So we'll work with you to make a list and understand which improvement activities for your TIN you want to track. And we can show you progress throughout the year on these improvement activities. And we can work with you on cost too. So we can take in some reporting that you have on cost and build you a sample dashboard that shows you on past performance how you're performing on cost, which will give you a baseline for how you might perform under that category going forward. So to show you the difference from an executive role to an analyst role or an informaticist role or quality coach role, they're not going to have a scorecard up front. They're going to have just the dashboard listing the various measures and activities that you're tracking. You'll be able to see for this measure, hemoglobin A1C poor control, how many met the denominator, performance met, performance not met, performance met, but most importantly, drilling down into the patient level details. So here's where we can help and show which patients met the performance, which didn't meet the performance and why, and if we have any data missing. So if it's clinical data missing, we'd be able to indicate what that clinical data value is. If we're working off of billing data, and we need the what's called the G code or the quality data code, that would be, we'd show a missing value here. We also offer smart forms, so you can come in and select that particular code. If you have it, you'd have to go back to your chart or your workflow and pick it, and then come into our system and be able to update it for that particular patient. We can also offer, I'm going to go back out one screen, we can also come in and give you the ability to track your advancing care information. So we can either take this in as an upload to this data, but we can also give you an editing ability. So you can come in and mark the denominator, numerator. If you need to exclude a particular measure, you can do an exclusion on it. So we can give you that ability within the portal. We can also give you the same for improvement activities. You can track them, and also have the editing ability to come in and say, you know, when did you start it? When did you end it? Is it in progress? Is it completed and you provided documentation, or you're still waiting for documentation, or has it been not started? We give you that functionality within the portal as well. And then the last is on cost. We can also give you the ability to come in and do estimates on cost too. I know I've gone through that a little quickly, but I'm happy to go into more details on this separately if anyone has any questions on this, but I want to be sensitive on time. So I'm going to go back to my deck. And so the first stage on that we offer with our process is with Christine's team at implementation, working with our clients to understand what their mix of eligible clinicians are and how to pick the best measures, you know, going forward. We'll work with them. How did you report in 2017 and 2016? So we have some history on which measures were utilized, whether for PQRS and now for MIPS in 2017. What's your provider mixture look like? And we can provide some recommendations on which measures to select. Once you've selected those quality measures, we can collect a sample amount of data, and I can speak through how we get data in a second, run it against those measures, and provide you back details on any gaps in data and then gaps in workflow. So similar to what I showed you in the analyst role or the informaticist role where you get the patient level details, we're going to provide that back up front in reporting and education through our team, so we can start to remediate any issues, any gaps in data, make sure you've selected the right measures before you go into an implementation. So we try to fix all that, quickly within our implementation process, and then get you to a portal where you're really just looking at practice workflow transformation and not getting into the weeds on any missing data at that point. And so we have the ability to work with many different data points. Clinical data, we're extracting data directly from EHRs or other formats, billing data directly from providers. We work with survey data. We're integrated with HIEs. We take in custom data sources. We populated an enterprise data warehouse from there. We have a team that's built our own enterprise master patient index to match the patients and harmonize it in. But speaking specifically to MIPS, there's three ways that we can take in data. So number one, from clinical, we can take in structured data from EHRs, a QRDA or CCDA file. We can also build in custom interface and extract data directly from EHRs. If data from the EHRs isn't complete or you don't wish to leverage that source, we can also take in billing data from our clients, so the 837 professional, the 837 pay, to process it. And where I said in the smart web form, if there's any clinical quality codes that are missing, the G code's missing, we can provide either smart web forms through our portal, or we can take in some flat file feeds as well. The same for advancing care and clinical improvement activities. We can do file updates to support that too. So once we have the data, we run it against the measures. We provide the dashboards that I show you. And as Christine mentioned, we're a qualified registry and a qualified clinical data registry, so we support all submission for MIPS. And we also support other programs like ACL, MSSP, GPRO submission, and providing solutions around an ACL, clinically integrated network. If you're also looking at measures for your commercial health plan, we can build you dashboards and hopefully leverage the same data to be able to support that program as well. And so just as a summary, we're ONC certified for all 29 hospital electronic clinical quality measures, support those programs on the left-hand side. On the ambulatory side, as a qualified registry and a QCDR, we're certified for all 64 ambulatory ECQMs, and also we can support all 248 qualified registry measures, plus we have 10 of our own QCDR customized measures. And then we've built measures supporting, ACOs. We built HEDIS measures supporting commercial plans, done a lot of work around Medicaid reform. CPC Plus we can also support, and STAR Medicare Advantage as well. And I'm wrapping up my slides, and then, finally, from a solution perspective, as you look at more of a population health perspective, whether that's to support an internal initiative or if you're moving into an advanced payment model such as ACO or CPC Plus, we can provide population health analytics as well around disease registries, risk stratification. We have our own risk models, creating ambulatory physician scorecards, geomaps, and put together a package of dashboards and actionable insights, as we like to say, for your team to utilize to affect the members before they end up, in your hospital. That too. So finally, what do we see as our key differentiators? We're working with various data points today for MIPS and other programs. We have the ability to aggregate that, to normalize it, and provide you back that in some visualization tools that can support CMS programs, that can support commercial payer programs, any internal initiatives, and provide you the analytics and dashboards to project and report clinical and financial performance, ultimately helping you close gaps, improve quality, and improve outcomes is our goal with our clients. And so, as a summary and what, Steve opened up with and the team, and we had the privilege of speaking to some of your member hospitals is to provide education with HealthCurve analytics. We just wanted to give a summary of some of the questions that we had received back that might be helpful to everyone on this webinar. So Christine and I will answer, kind of give a quick summary of what some of the common questions were and, our perspective on it. So the first is, my hospital is part of a large, system. Do I report my hospital individually or the health system report? And so there's two pieces to that. First, it depends on your health system if they're on their administrative policies. Some health systems will allow the hospitals to report for their TIN separately, and some will run that process through their health system. Even if your health system is taking control of that process, you still want to be responsible for your quality, particularly in closing gaps, looking at the measures and who's falling out of them, and working on that quality improvement, because ultimately your TIN is going to be affected on how you do in MIPS and the score and your financial, and ultimately you want to improve the patient care. So you still have to take responsibility for that. How will this affect payment adjustment for my hospital under a large health system? So Christine, I'll let you.
Yeah, so I guess it really ties back to how you report. As I said, most of the majority of our clients report as a group, the way that CMS defines a group is a TIN. So if the health system would have multiple TINs, each TIN report, each TIN would get a MIPS score, and each TIN would get a payment adjustment. So that payment adjustment is applied at the TIN level. If you are reporting as an individual, then essentially TIN combination. So it really ties back to the method and how you've structured in terms of the number of TINs under your organization.
Next question we received a few times was, how do I reconcile the use of multiple EHRs within my hospital? So one easy part for the eventing care is you can combine the reports from multiple EHRs and be able to submit it as one under a TIN. For the quality, it's really going to depend on which measures that you choose based on your eligible clinicians and their specialties and which measures best line up to them. So first, look at what's the best measures for your ECs, and then second, that'll kind of tell the story on what data that you'll need. If you can look at the electronic clinical quality measures, you can just leverage clinical data and be able to, if you can get that from multiple EHRs. If not, then you might want to look at claims data or some type of combination of claims and clinical data and be able to pull it all together. But first and foremost, what's the best for your ECs to report on, which measures best line up with them is our recommendation, then go from there. If an MPI worked for more than 110, what is the score used for payment incentives?
Yeah, so first off, I would always direct everyone to go to the QPP lookup tool that CMS has provided. Make sure that they understand for a clinician which TINs they're a part of and whether or not they're exempt or eligible for MIPS, whether as an individual or as a group. So say, for example, if you had multiple organizations that a particular clinician worked with, then there would be basically, say, if you work for 2 different TINs, each had a group score, they did reporting, that TIN would get the payment adjustment relevant to that TIN. So when that particular clinician bills in that TIN, that's the payment adjustment that's associated with that.
The last question, do penalties follow ECs forever?
Yeah, so the way that CMS has structured the program, they have the performance or calendar year, and then they have the payment year. And the payment year is always 2 years in the future of the performance or calendar year. So, for example, we're in performance year 2018. Payment year for this is going to be payment year 2020. So the way that the penalties are structured, it's only for the payment year. So say, for example, you had poor performance in program year 2018, such that you were going to be assessed that negative 5% penalty, then for every claim that started in January 1st of 2020 through December 31st of 2020, you essentially get that negative 5%.
All right, so we're going to go to the question and answer session in a second, but just as a reminder, we do have, as part of the relationship with HealthCurve Analytics, we've created a white paper around key components and challenges of the MACRA 2018 final rule. So if you'd like your copy of that for more further education, we'd be happy to distribute it. We'll have our contact information up in a second. Just reach out to us, and we can get that to you. With that, we're going to go to any questions that we may have and go from there. So questions? All right. Do you provide recommendations for measure selection? So absolutely. That's part of our readiness assessment process up front. We can certainly work with you, understand your clinician roster, makeup, your specialties, and help you based on past results, pick the right measures for you. So that's certainly a service we offer. Can you work with us to project scores for program year 2008? Christine, you want to take this one?
Sure. I think as Mark showed in the demo, we try to forecast the scores. So we do try to work with our clients to help them, provide some education about, which measures to select, and both, I guess, across all the different performance categories, which are going to optimize your score. So yes, I guess as part of readiness assessment, as part of working with clients throughout, and then as Mark showed on the portal, you can actually also see an estimate of your score.
Perfect. Okay. Well, I think that's enough. We're coming up on the hour now, so we want to be again sensitive to everyone's time and appreciative for you for taking part today. Hopefully, we addressed your questions and gave you a better perspective on MIPS and how we might be able to help your organization. Our contact information is up here, both Christine and I. So please feel free to reach out. And with that, I'm going to turn it back over to Brian Waterman to help us close out this webinar. And thank you again. Brian?
Yep. Thank you, Mark. And thank you, Christine from Spectrumetics. And for all those who attended from our participating hospitals, we're really, really glad to have you. Thank you for taking the time today. I really want to weigh in. Mark and Christine and others from Spectrumetics are really a wealth of knowledge around not just MACRA and MIPS, which we presented on today, but just really anything related to e-measures or the programs in general. There's a wealth of knowledge that is available to you. Please do not hesitate to reach out to them or to Steve to Steve Warshall or I if you'd like to set up a conversation to talk about where your organization is at. The nature of this partnership is really about member value. The nature for us is to make sure that our members are as prepared as possible for these programs. So with no further ado, I want to respect everybody's time, and thank you for participating today.
Thank you again. Have a great day, everyone.
Have a great day.